we wanted to really select those patients who might benefit most from immunotherapy. And neoadjuvant chemo and immunotherapy trials have been done. Several phase 1, phase 2 trials have been done. Dr. Conetti and I led the BLAST 1 trial when we were in Minnesota together. We combined gemcitabine, cisplatin, and nivolumab. We saw complete responses of 49%. As you can see in other trials, also it's quite comparable. And single agent immunotherapy has also shown activity in cisplatin ineligible patients in the PURE-1, Abacus, and other trials. But if we look at the neoadjuvant chemotherapy data, these complete responses are quite similar. So the question is whether the addition of chemotherapy to immunotherapy is necessary, or even whether immunotherapy to chemotherapy is necessary. There are several ongoing phase 3 trials that are being completed or have been completed. Energize is one such trial where nivolumab gemcis was compared to gemcis. It has completed accrual. We should see the data soon. And in cisplatin ineligible patients, there's several trials comparing upfront cystectomy to immunotherapy or immunotherapy plus antibody drug conjugates. None of them have reported so far. So in conclusion, neoadjuvant chemotherapy is the standard of care, should be offered when possible. Offer adjuvant cisplatin if neoadjuvant chemo is not given. My personal perspective on the VESPER trial is that 6 cycles of dose-dense DemFac is very difficult, like many of my colleagues said here. And gemcitabine cisplatin is pretty well tolerated, and I think, I don't know what the numbers here are, but in the US, we are still struggling with everyone being referred for neoadjuvant chemotherapy. So I think the goal is to offer them some cisplatin, whether it is MVAC or gemcis, that's not the big question. Immunotherapy is currently not approved in neoadjuvant setting, therefore it should not be used. And consider adjuvant immunotherapy in ctDNA positive high-risk patients, because we need to weigh the lack of overall survival with the costs that are for these agents in India. You know, each dose, I think, costs about 2 lakhs or so, and it's really not worth it if the overall survival data doesn't pan out. For our radiation oncologists in the audience, there's a lot of studies going on with trimodality therapy incorporating immunotherapy, but these are not yet read out, and it's not used as standard of care yet. Moving on to metastatic disease, platinums have improved survival in the frontline setting, whether it is gemcis, dose-dense MVAC, or gemcarbo. However, only a minority of patients get to second line, and we need to improve survivals and treatment approaches in the upfront setting. Several of the chemo and immunotherapy trials have turned out to be negative so far, so there is no data to combine chemotherapy with immunotherapy, and immunotherapy doublet has also not shown to be better than chemotherapy. So currently, they should not be used in the frontline setting. And in cisplatin ineligible patients, we saw that gemcarbo was actually as good as single agent pembrolizumab, or rather pembrolizumab was not better than gemcarbo, even in the high CPS scores. So therefore, frontline chemoimmunotherapy should not be used in metastatic disease, and gemcarbo should be used when possible and not frontline immunotherapy, because we saw that the response rates were lower with single agent immunotherapy and there were early deaths. But we've also seen that switch maintenance immunotherapy after frontline platinums in patients who don't progress is an effective approach. This was seen in the pivotal Javelin 100 trial, where frontline patients got 4 to 6 cycles of gemcis or gemcarbo, and then they were randomized to avelumab versus best supportive care if they did not progress. So if they had complete or partial responses or stable disease. Primary endpoint was overall survival. And as we can see here, there was a significant improvement in overall survival and disease-free survival. It was more pronounced in PD-L1 positive tumors, but we don't currently need to check for that. Also want to add here that can substitute avelumab with pembrolizumab based on the phase 2 Hoosier study that was led by Galsky et al. and it was not a registration trial. However, there was benefit of pembrolizumab, and depending on the cost and the logistics of pembrolizumab versus avelumab in India, one can make that decision. In platinum refractory setting, immunotherapy has shown survival benefit with pembrolizumab. However, there's also other checkpoint inhibitors which were approved on single-arm trials. Therefore, depending on the cost-benefit ratio and what the patient can afford, one could use any immunotherapy in this setting. So in conclusion, platinum chemotherapy is the standard of care for frontline therapy, and only when a patient cannot get even carboplatin or is truly platinum ineligible should single agent immunotherapy be used. We should offer maintenance immunotherapy after platinum chemotherapy, pembrolizumab or avelumab, whatever is more cost effective, and offer second line immunotherapy whenever possible. So key takeaways for use of immunotherapy based on the practice patterns in India: it's not recommended in non-muscle invasive bladder cancer, not recommended in neoadjuvant setting, but is recommended in adjuvant setting in select cases, and it's recommended in metastatic setting in the maintenance as well as platinum refractory. I have 3 minutes to spare, so that gives us a lot of time for questions.
Thank you, Dr. Shilpa. I think you have concluded in your last slide very well. But I will definitely ask you some question because of the practical things which we face. How to optimize neoadjuvant chemotherapy in not every patient will respond. Problem is this, especially T3, N1 node, they generally do not respond. Then there is some type of, even we don't have molecular classification in practice, but then you have eschamoid differentiation, glandular differentiation. So how do you do in your practice, and what do you suggest?
So you're right, we are not using molecular classifiers to make the decision for whether to offer chemotherapy or not. But if a patient has locally advanced disease, we should just offer platinums and see if they respond, and if they're resectable, then proceed with surgery. But when possible, do give neoadjuvant treatment. I think with the lack of data, whether immunotherapy plus chemotherapy is better or not, I don't recommend using it in the neoadjuvant setting at this point.
So what about these two specific situations, like patient who has got eschamoid differentiation and glandular differentiation? Will you give NACT, or you will prefer to do the surgery?
For glandular differentiation, we are giving NACT unless it's pure adenocarcinoma. And the other one you said is sarcomatoid, right?
No, eschamoid differentiation.
So pure squamous, we recommend upfront cystectomy. But if it is predominant urothelial with squamous differentiation, we're still offering neoadjuvant chemotherapy.
So just to extend this question a bit further, you've given neoadjuvant and you find that the situation is status quo. It has not improved, it's just there only, and it's still locoregional disease. Then how do you proceed if the patient is not amenable to surgery?
So you do a cystoscopy and there's no downstaging?
The response is not there, it's just the same.
And patient does not want surgery?
At that point of time, the patient cannot be taken for surgery.
I think in such cases, one could consider chemoradiation after neoadjuvant, like is done in the UK. I'm sure Dr. Tree will talk about that at some point.
Maybe you can add.
Can I ask a question here?
Right. 1 second, she can make a comment. Patient who has undergone NACT and it is status quo, and still it's locoregional, not amenable to surgery.
Yeah, the real world scenario is basically when patients come either neoadjuvant or adjuvant setting is the creatinine renal function, because many patients are diabetic, hypertensive, partial obstructive uropathy. So how do you circumvent? I mean, is there a choice between DDM-VAC, or obviously it has been said that carboplatin is not as effective as cisplatin. So what's your take on that? Real world scenario, altered RFTs, and how do you go for NACT and adjuvant
So if a patient is not eligible to receive cisplatin, they should not be offered carboplatin in the neoadjuvant setting. And they should be taken up for surgery if they are candidates. If they're not candidates for surgery, then they should be offered chemoradiation with gemcitabine or